Hello and welcome to this presentation. First of all, thank you for having me for this meeting, and thank you for your attention so that I can present our research to the practical oncologists in Korea. We have been involved in treating patients with modulated electro-hyperthermia in the last 7 years, I would say, and we have designed studies to gain data on the treatment of, first of all, pancreatic cancer patients who were of inoperable nature. Before I would start with this, I was just going to go through what is this method and why we use it. So this is a device by a local company designed and in practice for about 40 years already. So our department already had used this device in the 90s, and we collected over the years the results and published a review about the utilization of this method in a comprehensive journal. So modulated electro-hyperthermia is a current which goes through the body, and it has several mechanisms of action. First of all, it is changing the flow of this current in between the tumor cells, which is the Sanderdi phenomenon, and the energy gets absorbed in the membrane, and it is changing signal transduction and also metabolism of the tumor cells through the Warburg effect. And we see that there is a controlled blood flow in the region due to the thermal effect, and there is a immunological effect of this method in the environment of the tumor. So we very much consider this treatment now a method of immunotherapy, which can concomitantly be used besides oncological treatments, including radiation or medical oncological treatments. And it is improving the response rate and the survival rates and the quality of life of the patients. So when we look at the evidences we have in the literature, there are phase 3 clinical trials related to cervical carcinoma, and the level of evidence is highest in this disease group. However, many publications and treatments go on in central nervous system tumors and even in lung cancer. In our studies, and I think the next level of investigations go for the liver, biliary, and pancreatic tumor region besides the small pelvis. If you look at pancreatic cancer, we see that this is a really poor prognostic cancer. That is why we have chosen this tumor type in our department from the available solid tumor cases. So we can see results in a much faster way, and we can also, there is pretty much room to help these patients. So in a localized stage, which is really low in Hungary at the diagnosis, we have a good and better survival than in the ones that spread to the regional lymph nodes or even metastasize further beyond the primary tumor location. As mentioned, the 5-year survival is dismal, really poor in these metastatic cases, and we went on to treat our advanced case patients. So just to review, we have looked in the literature also what is the possible utilization and the previous evidences that support our decision to treat the tumors of the hepatopancreatobiliary system. So we performed a literature review, and out of these hundreds of publications, we have investigated 39. But we have seen that the median overall survival really favors treating these tumor types with hyperthermia. So it is really an evident shift in this forest plot to the right, which favors the utilization of hyperthermia treatments. If you look at the disease-specific and the control rate, we have also seen a similar shift to the right, which very much supports the utilization of hyperthermia in pancreatic cancer. We had a single-arm study, actually. We treated in a prospective manner a consecutive cohort of pancreatic cancer patients in our center, and these were about 40 patients. And we could do a case control study comparing them to our patients who did not have hyperthermia. They received various lines of treatments and various chemotherapy protocols, mostly gemcitabine-based combinations or monotherapy. The overall survival was just slightly better for the modulated electro-hyperthermia group, but it was really significant when we have seen the statistics, even in progression-free comparisons and the overall survival. So the 1-year overall survival was increased from 41 to 66% in our patients. And we have seen a tendency over the 2-year survival as well. The progression-free survival was almost doubled at 1 year. So we have seen the Kaplan-Meier curves that favor our treatment with modulated hyperthermia, even though, as you can see, this is not really convincing at this point because there are very low patient numbers and the standard deviation is high. But I just wanted to draw your attention to the fact that we have seen that ascites formation in itself can distinguish between the responders. So we have seen that the patients who do not form ascites respond much better over time and have a better prognosis during our treatment and with the overall survival. When we look at the study from this Italian cohort by Professor Fiorentini and Donatella Sarti, they have performed a stage 3 and 4 pancreatic cancer study in a prospective manner, and have seen that if they add concomitantly modulated electro-hyperthermia to the patients treated with chemotherapy, they received a much better response rate, and even clinical responses were seen, and partial responses from the patients in a much more efficient rate as compared to the progressive disease. So they have similar Kaplan-Meier curves displayed, which show that the outcome was much better with the hyperthermia treated group as compared to standard chemotherapy only. In our previous cohort at our center, when we have performed just a data collection and to see the patients in this smaller subgroup back 4 years ago, that we treated our patients consecutively without any selection. And we have seen that these small dots represent weeks in treatment. If the treatment goes on, that is a dark gray dot. If there was a break for any reason, for instance, one of our patients who was a really long treated patient, he had several breaks in the treatment, and these are displayed in light gray. If the treatment was stopped, then we display it with a pinkish or reddish dot, and if the treatment went on, we have the green sign at the end. So I just wanted to show you that our median treatment was about almost 20 weeks in our patients, and we treated them 3 times a week favorably. If they couldn't manage it, then at least 2 times. 1 hour reaching to the power of 150 watts with this device. And we have seen extraordinary long survival in several patients of ours. And as you can see in the patients above the median survival, we see that they had several stops, breaks, and weeks when they didn't get treatment. And if we see and treat a lot of patients, we observe that there are many who develop some kind of an intolerance towards hyperthermia. And I think these breaks helped not to develop any resistance and intolerance, and these patients could have been treated for a longer session. So, but I want to imply and suggest, if we go on with these treatments, it's really wise to have even a few weeks breaks during the treatments. If the patients go on for long-term treatment sessions, many times a week, then it's also very good to introduce some breaks to prevent intolerance of thermic treatments. If you look at other studies from other clinics, we have seen that if we have this is just the survival in months on the perpendicular axis, and if we compare as control groups, we see the European and the US data of 10,000 of pancreatic cancer patients. The survival seems to be in between 1 and 2 years. If you look at the treatments from various clinics where they apply modulated electro-hyperthermia in actually smaller groups, of course, of patients, because these are small clinics, but evidently they tend to have a longer survival for the patients in the metastatic setting, and a larger proportion of patients go on and live with fairly good life quality with pancreatic cancer. So the average is about 40 months, and about 3 times enhancement can be seen. We published guidelines for local hyperthermia treatment in oncology, and this is not limited to pancreatic cancer patients, but this is supposed to show further information and provide guidance if somebody wants to go on and treat patients with modulated electro-hyperthermia treatments. Thank you for your kind attention, and I'm really happy to answer to questions from the distance if I get them forwarded to my email address. I'm happy to respond to you. Thank you for your attention.